why feline esophagus? This is like a double contrast esophagogram, and you can see the multiple thin, multiple thin folds in the lower esophagus. Good evening, yes, everyone. Hope everyone is doing well and doing well after Eid. Okay, so this is what is called feline esophagus, and you can see that it is like antimony case with this transverse folds. Okay, so this is what's called feline esophagus. Yes, multiple thin folds. This is like normal variant. Can come to you as a short case. So what about this one? This is a single contrast esophagogram, and yes, there is perfect Marwa, NA, Nermine. Okay, so this is what's called diffuse esophageal spasm, and it happens when there is some contractions. Yes, numerous some contractions, and it looked like a corkscrew. Yeah, corkscrew appearance. Perfect, Marwa. So this is what's called diffuse esophageal spasm. Manometry is the gold standard. Okay. So this one is a bit difficult, but we can imagine that this bowel should be the small or large bowel. Is it a small bowel or large bowel? Yeah, so this is small bowel, Marwa, nice. And the small bowel here is dilated overall with sac-like appearance. Multiple outpouching is not very common, but it can happen, yeah, with maybe incidental vitamin B deficiency. Yeah, so this like small bowel diverticulosis. Yes, small bowel diverticulosis. Again, is not supposed to be in the exam, but just to know. This one is important to know, and they like it in the exams because you have this congenital traumatic inflammatory neoplastic scheme, and we always like forget that there is one of these items that you should think when you have your differential, what is called drug related or medications, right? So this one, it can be from hyperdensity in the liver, diffuse hyperdensity. It can be from something called amiodarone therapy. Perfect, Ala. Marwa, yes. This was called amiodarone therapy, and you imagine that also in the lung, it will be affection in the lung, right? So what happened here? Heart failure, enlarged heart, perfect. And this patient take amiodarone for the treatment, and he developed what is characteristic for the consolidation also here. This consolidation, what the characteristic? It is hyperdense, yeah. So when you find hyperdense Rihan, perfect, Nirmin, and you also find the liver hyperdense compared to the other organs, so you are talking about one of the treatment called amiodarone therapy. So your differential, sure that it will be other. What it could be? Some diseases which have similar appearance with iron deposition. It will be hemochromatosis, perfect. With copper deposition will be Wilson, nice. And with glycogen deposition will be glycogen storage. And with gold, as again, there is some gold therapy. Yes, nice. So that's what is called amiodarone treatment, high attenuation liver. They like it in the exam, MCQ, everything. So this is what's called hemochromatosis. We talk about it, and we say that the pancreas, primary and the secondary is the spleen. So you should look in the spleen. Yes. Again, hemosiderosis, and here you can see that the spleen is affected. So it is primary or secondary? Secondary. Nice, Rayhan. NA. Amna. Nice. Welcome. Okay. So okay. So what about multiple? You can see something. Yes. These things. Multiple non-enhancing hepatic focal lesions. Differential diagnosis. Nice. What is your differential diagnosis? Okay. Microabscesses, TB, sarcoidosis, metastasis. Yeah, don't forget metastasis. Nice. Metastasis, you can put it in every differential, and lymphoma, and also sarcoidosis, to be honest. So one of this, it will be candida. Okay, infection as candida and other infection types. Yes, lymphoma. So this one, it was, yeah, like what NA told us. I don't know who is NA, but yeah, he told us it would be biliary hamartomas. Especially after you see the MRI, which have some characteristic with high T2 appearance, and there is no contrast, but you should have the contrast to be sure that there is no contrast after injection. So after injection of contrast or post-contrast T1 fat set, you don't have any contrast in this lesion, then you are going that maybe it is cyst or hamartoma. With this appearance, you can go that it is cyst. Perfect. Starry sky sign. Okay. They also call it Meienberg complexes. As you see that all are small, benign lesions. It can be incidentally discovered. Nothing clinical significant. Von Ala, yes, Meienberg, perfect. In the CT, as you see, it was hypodense. In the MRI, it looked like a cyst with no enhancement. And maybe in the ultrasound, you can see something like artifact because it can have like cholesterol, which give you this appearance. So this was called biliary hamartoma. Know it for differential. So this another case. When you see CT, please go and check which phase are you. So if you are in this phase, 2 phases, so you are going that maybe there is one lesion here, right? And this lesion take in the arterial, and it is indistinct in the portal. So yeah, insulinoma, it will be one of the best differential diagnosis because it is hypervascular and it is in the pancreas. So islet cell tumor, what is the most common one? It is insulinoma as NA, and yes. So neuroendocrine tumor again, yes, it is neuroendocrine tumor. And what is the second common one? It is gastrinoma, which is much bigger or small, small, and it associated with which syndrome? Gastrinoma. We saw it before. Zollinger-Ellison syndrome. Perfect. Yeah. Nermine, nice. And we mentioned when you have any neuroendocrine tumor, and we mentioned this before. There is also one category, it's called non-functioning tumors in the islet cell. So they tend to be malignant. Yeah, tend to be malignant. The most important differential diagnosis, as Ala told us now, vascular metastasis from renal cell carcinoma. So when you saw it, either islet cell tumor or vascular metastasis. And most important to mention that maybe it is renal cell. So look for the kidneys. If you find one kidney absent, then probably it is metastatic from previous renal cell carcinoma. Okay, so this is what is called islet cell tumor. And as we mentioned, the most important to know that it have hypervascular metastasis. Okay. as a differential. Yes. And here in the ultrasound, you can see it is not very easy. In the ultrasound, especially if the patient have gases, but okay. This one is anti-mini case, which is very famous, and it is like opposite to the appendicite in the right side. So it is in the left side. Yeah, Ala, Nermeen, nice, perfect. So this is what is called epiploic appendagitis. It is like a torsion of one of the appendages of the colon, nice, and there is some ischemia happen. So you can see the stranding around this appendages, and the most common site is the sigmoid. So what it will be the differential? Omental infarction. But omental infarction, the typical site for omental infarction to be in the right side. Perfect, Marwa. Shayma, nice. So this is what is called epiploic appendagitis. Yeah, appendagitis. Okay, and as we mentioned, the omental infarction, the most important, but always it is in the right side. Okay, let's shift to another case. When you find splenic focal lesion, what will be your differential? Yeah, so what is the ring sign? Differential? Okay, yeah, so hemangioma, lymphoma, abscess, angiosarcoma. Wow, very nice differential. So why you are going to be metastasis or lymphoma? Nice. So if it is metastasis, sure that you will go and search for primary, yes, and it can be rare metastasis, yes. So what is the rare metastasis? If it is rare metastasis, where it should arise from? This metastasis, perfect. Melanoma, breast, and but don't forget BB, breast and pulmonary. Yes, yeah, breast and pulmonary can go everywhere. So yes, and ovary, yes. And sure, the second differential will be lymphoma. Yes. So and also, as you mentioned, many benign lesion, hemangioma, cyst, hamartoma, siderosis, but it's very small, candidiasis, but also again small, infarct, but it's not typical, cyst, but not this appearance. So you can put everything, but lymphoma and metastasis will be the best differential. So this one, it was splenic metastasis from melanoma. Yeah, Rehan, perfect. Okay. So this one in the spleen is not typical, but you can say so it is candidiasis. And again, another appearance of candidiasis that maybe it can happen everywhere. Yeah, with infections. They look like, they say that look like punched out. Yeah, lesion. But to be honest, if you are in the exam, so both differential, the mets and lymphoma, it will be in your top differential. Then after that, you can put everything, okay? Maybe from the history, you can know it, yes. So if you find calcification around the lesion in the spleen, as you see here, so it is granulomatous, and one of the most important granulomatous disease will be the hydatid. Yeah. Again, the spleen, one of the most important to mention in the differential, sarcoidosis. So sarcoidosis, lymphoma, metastasis everywhere. Hemangioma, and it look maybe like the liver sometimes, yeah. And finally, the what's called siderotic nodules in the spleen. Nice. This patient underwent liver transplant, as you see. So what happened here? Yeah. So why you mentioned that it's biliary necrosis, Marwa? Yeah, because nice, there is some edema and like a fluid density or hypodense fluid density, hypodensity around the vessels, yeah, the portal vein. So this is maybe it is like a biloma, yeah. So what is beside the portal? It will be the biliary tract. So maybe it is a biloma. And if you think about biloma that extend everywhere, and this patient have liver transplant history, so you are going that maybe what happened that there is perfect ischemic of ischemia of the hepatic artery or stenosis or thrombosis, yes. So if this happen, yeah, will be the what is called bile duct necrosis. Nice. Near mean, yeah, rejection. Okay. So when he give you this, that there is history of liver transplant, remember that with severe hepatic artery stenosis or thrombosis, it can happen this bile duct necrosis. This patient underwent gastric bypass, yeah. So yeah, they like it in the MCQ. What's the like most common? One of the most common complication happen after the gastric bypass. Yeah, leakage is nice, but is not leakage because you should see the contrast outside. What do you think? Is it outside? I mean, there is a contrast here. Ah, okay. So you mean this one? Ah, yes. So maybe this one, like it should be the stippling. Yeah, nice. So the stippling line, there is some dehiscence happen and the contrast go outside. Nice. So I agree with you that there is leakage. Nice. So this what is called gastro what? Gastrogastric, yeah? Fistula. Yeah, gastrogastric fistula. Yes. Okay. So the complication could be leaks, could be in the site of anastomosis, could be like narrowing or stricture, could be gastrogastric fistula as this one. Okay. Could be that the excluded part of the stomach can recover again and can be distended much more, right? And ulcers or infection can happen also. Okay. So post-operative gastric bypass complication. This one, it was what's called stable line dehiscence, as you see, with gastrogastric fistula. So, sorry. So they mentioned that the contrast material was opacifying the fundus, okay? But after that, and the excluded stomach, okay? But there is no contrast material in the body of the stomach, okay? So what happened here that I think this line is dehiscence, and it shouldn't be like this, yes. Okay, let's see if you, I will finish this presentation and we can focus in, have a look in the gastric bypass complication in quick. Okay, if you like, we can go through them, okay. So this also can happen with the gastric bypass complication like splenic infarction and liver infarction and other. So this one is very common even in the practice when you see this appearance. And look in this phase, it should be arterial phase. And as you see that the spleen, Marwa, nice, is shuttered, perfect. So this patient, you will ask about the history and sure that it will be trauma, yeah. And there is active, yeah, active hemorrhage, active extravasation, yeah. So shattered spleen. So maybe the grades, as you know, is important to know that there is grade 1 subcapsular hematoma and grade 2. And you say that maybe laceration, they have much details, laceration from 1 to 3 or above the 3. And I think this one, what we have here, shattered spleen with vascular injury. Perfect, 5, Marwa, nice. And also, yes, nice, the surgical emphysema. And more important than the surgical emphysema, that the patient have what? No, perfect, Ala. So I have pneumoperitoneum. So yeah, any patient with trauma, look for the pneumoperitoneum as first. Yeah. Okay. The trauma, they like it in the exam, sure, because it tests in you the basic and the emergency requirement. Okay. Let's go to this one. It's a bit, maybe it is like, you can see something here. Here. Yeah. So what is this? Maybe we can consider it like multiple gastric filling defects. And if there is, yeah, we will start with polyps. Maybe it is polyps. Maybe it is something like hamartomas, lymphomas, mets, varices, yes, adenoma, nice. So it will be the, we mentioned it before, gastric polyps as differential of multiple gastric filling defects. Could be hyperplastic, could be adenomatous or hamartomatous. And you remember the familial polyposis diseases and so on. Okay. Let's go to this one, which is antimony case. Okay. And yeah, what we see here is, yeah, Nermeen, 1 star. Yeah, severe vein of Fauzi, Dr. Fauzi, Dr. Marwa, Nermeen. Okay. So this is very famous in the exam as a short case. What is called hot liver sign, okay, hot spot sign. And they denote that there is superior vena cava obstruction. Yeah, Sarah, you want this maybe? So I will show you something. You mention it. This is what's called hot quadrate sign, spot sign. Yes. So this is in the something called technetium sulfur colloid scan. It looked like, yes, increased retrotracer uptake in the left loop. Yeah. Yeah. Okay. So this what is called hot quadrate spot sign. Yes. So hot quadrate sign should denote that there is superior vena cava obstruction. And what happened here in this case, that the collateral is open. And when the collateral is open, so it shows you this appearance, right? So what is the collateral pathway? It comes from the internal mammary vein, then para-umbilical vein, then finally the left portal vein. Yes. So this could be, this should be segment 4. And as we mentioned in sulfur colloid, there is increased uptake again in segment 4. Yes. Yeah. Let's go to this case, which is a bit easy case. This man is old and as you see, this is double contrast esophagogram, and yeah, Schatzki ring. What is Schatzki ring? Yeah, it is like a prominent P perfect. Shrihan Nirminia. So this, it is like ring, and it is prominent P ring in the distal esophagus that limit passage of the barium. Yeah. Okay. Let's go to this case. Yeah. So when you find there is a contrast, yeah, this contrast extravasated but extra luminal. Yeah, you can be say extra luminal. Extra luminal contrast, and as you see the contrast from the esophagus, then the esophagus rupture. Yes. So one of the best differential, as Marwa told us, Boerhaave. Leakage can be if this patient underwent recent operation. So Boerhaave is like coming from vomiting, chest pain, yeah, from straining, or maybe blunt trauma, yeah. So this is what is called Boerhaave syndrome. So happen with blunt trauma, with vomiting, straining, the esophageal will rupture and the contrast go outside. And it happened in the left or right side? In the left side, yes. More common in the left side and in the left posterolateral wall, the hand perfect, yes. So Amna told us very nice description about the difference between Mallory wheeze, which is left and its partial thickness tear, but Boerhaave is full thickness tear, yes. So let's finish with just to stop sharing for a moment, and I will show you something else. So as a quick revision, so share again screen, and we can go to the, yeah. So this one, I find this very nice presentation, which is by our colleague Dalia, which is collecting the signs of the GI. Just we can go quickly in this presentation. I find it like very nice just to make refreshment for us. So if you agree, we can take it quickly. Okay, let's have a look. So this what's called, yeah, window stock sign. It is like intraluminal duodenal diverticulum. We mentioned it before, if you remember. Yeah, duodenal diverticulum. This one is conical narrowing of the antrum, as you see here. What's called ram horn sign. Okay. This one we mentioned. Yeah, perfect. Ala. Pseudomembranous colitis, ischemic colitis, idiopathic bowel disease. You remember the differentiation between the cecal and sigmoid. So the cecal is the imperio sign, yeah. You remember the differential we mentioned before, malignant and benign ulcer. So Carmen was with malignant, and what is it with the benign? Hampton, yeah, Hampton, nice, Hampton sign, perfect. So this is what is called the Hampton sign. Remember the reverse between the jejunum and the ileum. So if it is reversed, then you can suggest celiac disease. Remember the Crohn's when we mentioned the cobblestone appearance? Okay, and this is the cobblestone. Nice. I like it. A granular mucosa, you remember the ulcerative colitis and the haustral lead pipe appearance. This is what's called pneumatosis cystoides intestinalis, which is a benign, you remember. And the most important to differentiate it from the free air and the portal venous gas from, venous gas. So, and this one, it was a polyp, which is sessile colonic polyp, Fowler head sign, Mexican head sign, okay. Bullseye lesions and the differential diagnosis from metastasis, lymphoma, Kaposi sarcoma, string sign with Crohn's, sorry, here. Bear necklace sign, adenomyomatosis, we show it you. I like this necklace again. Conical cecum, yeah, TB, and the differential again, we have differential, good differential. Something called Beckett-Vance pattern, which is acute small bowel ischemia. This can describe it as submucosal hemorrhage, narrowed loops. Stack of coins, scleroderma, you remember it? Fold thickening, submucosal edema or hemorrhage, and it have good differential, you remember it? Either smooth or nodular, right? Mushroom sign, who like mushroom? So this is CHIPS, congenital hypertrophic pyloric stenosis. Familial adenomatous polyposis, okay, and you can see, yeah?
Desmoid.
Okay, desmoid, perfect, yes. Nice. So what was the disease with desmoid? You remember? We mentioned it. What it was? Gardner. Nice. So again, familial bulbosus of mandible. What is in the mandible here?
Osteoma.
Osteoma. Perfect. Here, what in the neuro? You remember?
Medulloblastoma.
Yes. Nice. And flip-flop appearance was Bud Carey. Yeah. And this one, you remember when we talk about cholangio and when we mention cholangio and when we mention confluent hepatic fibrosis. So this one is confluent hepatic fibrosis and pancreatic lipomatosis with cystic and this disease which is diamond, okay, diamond, and any steroids also. Capsular retraction again with cholangio. You can see the difference here easy with this mass appearance, yeah. And also the dilated biliary radicals. Again, hotspot sign, superior vena cava obstruction. Fat ring, mesenteric paniculitis. Cocoon sign, which is sclerosing, encapsulating peritonitis. Very rare. Okay, you can see how it become capsulated. Yeah, and differential will be TB. Okay. Bunch of grape sign. IBMN. Imagine that you eat grapes. Yeah. Hourglass, cooler sign, diaphragmatic hernia. Hyperattenuating ring sign. Again, epiploic appendagitis. Mesenteric paniculitis, misty mesentery sign. Spider web by Buerhaave syndrome, we mentioned it. Left paraduodenal hernia, you remember it. Gathered lobe in a mass-like fashion. It is internal hernia. Some small bowel feces sign, which is open lobe obstruction. Hamburger sign, wow. Non-Hodgkin lymphoma. Target sign, liver metastasis, inflammatory lesions of the bowel. You remember it? Okay. wall echo shadow sign, Golis and shadow, posterior shadowing, right? Okay. And here the honeycombing and something called hepatic myelidosis abscesses or abscess, yeah. Foramen of Wenzel hernia, which is type of internal hernia, anterior to the IVC and posterior to the hepatico-duodenal ligament. So include the portal vein, the common bile duct, the hepatic artery. So it is the landmark to be anterior to the IVC and posterior to the hepatico-duodenal ligament. Right paraduodenal hernia, fossa of Valdayer. It is behind the superior mesenteric artery. So fossa of Valdayer, yes. Right paraduodenal hernia. Left paraduodenal hernia, we mentioned it before, through fossa of Landesert. Inferior mesenteric vein lies in its anterior wall, this one. Right? Yeah? Okay. Accordion sign, pseudomembranous colitis, we mentioned it. And acute appendicitis, something called arrowhead sign. Combe sign, Crohn's disease. Sclerosing mesenteritis versus mesenteric carcinoid. Donut sign, who like donuts, intussusception. Champagne glass. There is another champagne glass in the pediatric, but here champagne glass sign emphysematous cholecystitis. Even we don't drink champagne, but okay. Emphysematous cholecystitis and target fat sign. Okay, target fat sign, chronic, like this. You see the fat, yeah. So chronic Crohn's, ulcerative, or chemotherapy. Okay, so yeah, we still have, yeah, sawtooth appearance with Hirschsprung disease. We will mention it in the pediatric, but okay, you can take it. Pneumoperitoneum, air on both sides of the bowel loops, regular sign. There is pseudo-regular sign. Yeah, Rehan, perfect. Yeah, achondroplasia, this is the champagne glass. Yeah, the champagne glass mentioned here in the emphysematous colitis and will be mentioned in pediatric with achondroplasia. Yes, or achondroplasia. Yes. Pneumoperitoneum, midgut volvulus, corkscrew appearance, tram track sign. Is it? I'm quicker. If there is anyone missing anything, we can just you can repeat. Necrotizing enterocolitis, tram track appearance due to pneumatosis intestinalis. Yeah. Okay. Football sign, pneumoperitoneum. There is much signs of pneumoperitoneum. So this is one of them. Football sign. And triangle sign, again pneumoperitoneum. Falciform ligament sign. And let's just try to make it a bit, yeah. So this one is Meconium ileus, ileal atresia. We will talk about this in details, but he make like a contrast enema, and this infant who had failure to pass meconium. So he will do like contrast enema and will look in the microcolon. If it's microcolon, so you have to differentiate either ileal atresia or Meconium ileus. Okay. If no microcolon, so it will be either normal or there is Meconium plug syndrome or Hirschsprung with sawtooth appearance. Okay. So this is what is the differential. Okay. And thank you, Dr. Dalia, our colleague, for this nice presentation. Okay. So